Hi, I'm Rosie Claverton. I'm a crime novelist who lives in Cardiff, and today I'm going to talk about 5 common confusions about mental health in fiction. Extra info about me, I'm also a psychiatrist, so I'm coming at this both as a writer and a mental health professional. First up, psychiatrist or psychologist. There can be quite a lot of confusion about this in fiction. I think it's mostly to do with our consumption of American crime fiction and crime novels. In the States, psychiatrists have a lot more psychological therapy training than we do here. So you often see them doing quite a lot of different things on TV. Um, in the UK, a psychiatrist is a medical doctor who's gone to medical school and done general medical training before specialising in psychiatry. Their job tends to involve making a diagnosis, signposting people to various things they think they'll find helpful, and prescribing medication, as opposed to a psychologist. Now, psychologists come in lots of different flavours, or rather, therapists come in lots of different flavours. A clinical psychologist is someone who's undergone psychology training, usually has a PhD, so may also be a doctor, and has spent a lot of years perfecting the way of understanding how people think and behave. And they tend to work with people through talking therapies. So they'll do an assessment with somebody, maybe including a diagnosis, and then we'll work on a specific problem they might have, perhaps coming to terms with something in the past, or working on some difficulties they're experiencing now. You also get different flavours of therapist. So, for example, you might have a counsellor, and that's someone who tends to have particularly a counselling course training, or you might have a therapist that works with a specific type of therapy, so like a cognitive behavioural therapist, which is a type of therapy about how you think and behave that's useful for things like anxiety and depression. As you can see, this can get really confusing when you're reading about someone in a book who's having a chat with somebody about some of their difficulties. Who are they talking to? Are they talking to a psychiatrist, someone who's also maybe giving them an antidepressant or some other kind of medication? Or are they working with a psychologist to come to terms with some kind of trauma? You get this kind of situation a lot in a police procedural. You get the whole you've been in an active shooter incident, or you've had something terrible happen to you on the job, you've got to go to therapy until you can get back on the beat, and they hate it and they don't want to go. And there's a certain degree of skepticism around that, mainly because enforced therapy is pretty hard to make work. You've got to be motivated to want to change how you're thinking and feeling. But this is the kind of scenario that you often see in fiction, and that person would usually be a psychologist. They may also be a counsellor or specific therapist. If there's a particular traumatic incident, then they might be specialised in a therapy like EMDR. You often see that in particularly dramatic therapy scenes because it involves eye movement. So people like the kind of watch pendulum type hypnosis from a style, or the symmetrical tapping. And that can be very visually evocative. So you might see that quite often in crime dramas when they're trying to emphasize a point about trauma. So, point 2, distressed or depressed. This is one of my particular bugbears in fiction, and it relates to the experience of sadness. So often some major event happens to a character, a loss of some kind, or again something traumatic, and what you'll see is they might, if they're a masked character, grow a beard of sadness, take to drinking a lot of whiskey, push everyone away for about 30 minutes of an episode, and then they'll shave off the beard and get in the shower and get right back onto the work. That is misery. I call it the beard of misery. For that particular reason, like, this is sadness. This is a grief reaction, certainly. As I said, it usually relates to loss or bereavement. But it's not what depression looks like. we've seen in recent years much better representation of depression, I would say. You tend to get that longevity of depression. Like it's not a one and done thing. For some people it is, but for a lot of people it goes on for weeks or years, comes back. Or people also have degrees of function when they're depressed. So I think we often think about people taking to their beds, maybe oversleeping, eating or not eating too much, um, and that, as I said, that kind of unwashed, unshaven, unkempt kind of thing. And then a lot of people are depressed and just getting on with their day. And there's a lot of kind of functional addiction in crime fictions, kind of the cliche of the hard drinking detective who still manages to solve all the crimes. But you don't see as much functional depression. And I think that's really interesting that we don't talk about that perhaps it's a more comforting fiction, that it just goes away. So I think there's a marked difference between someone being distressed in fiction, appropriately distressed, and being depressed in what we would consider to be the medical term depression. Point 3, psychotic or psychopathic. This is a really common confusion. So you often hear these words used interchangeably in crime fiction. You might also hear them used interchangeably in the press or in common conversation. They are completely different things, and it's actually really stigmatizing and dangerous for people who experience psychosis to be conflated with people who have a psychopathy label attached to them. So what is psychosis? Psychosis is a difficulty discerning your own thoughts from the reality that's experienced as a shared experience with everybody else. So often that means experiencing hallucinations, so maybe hearing, seeing, feeling things that other people don't hear, see, or feel, or having what are called delusions, which is when you have ideas or beliefs that again don't fit what other people might think or believe. And that's distinct from things like religious beliefs or even widespread conspiracy theories. That wouldn't cross into delusions because it's a kind of communally held belief. And also you can get other strange phenomenon, like people thinking that their body is being controlled by someone else, or thinking that things on the radio or TV or in newspapers are about them. You can also get really specific psychoses. And I know there's at least one detective who's carrying one of those. So they can make for compelling reading. What they are not is psychopathy. Now, psychopathy is pretty controversial in itself. So there's a famous psychologist called Hare who developed this idea of the psychopath. And essentially, it's considered a subset of antisocial personality disorder or dissocial personality disorder, which is where you behave violently or in a way that's against the laws of society in order to get what you want. And there's also a degree of emotional stress attached to that in traditional antisocial personality disorder. I'm wary about talking too much about this, only because mental health diagnoses and categories change all the time, and we're kind of going through a big shift with the what's called the International Classification of Diseases at the moment. So that may all change very shortly. But psychopathy is different in that it was kind of coined by one particular psychologist, and it's particularly about what we think is the way someone's brain works. And you often get references to this in crime fiction about, we knew he was different as a child. So you get this kind of callous, unemotional child. There's usually some kind of reference to bullying, torturing animals, the classic pulling wings off flies type thing. You get a lot of this in fiction, so you probably recognise that description pretty readily. And then as adults, psychopaths are meant to not experience feelings and empathy in the same way that other people do, which can, in certain circumstances, lead them to commit crime, including murder. It's a very common serial killer trope. However, I think you can probably see that comparing psychotic people, people experiencing psychosis, to psychopathic people, people with the label of psychopath, can be damaging. So there's already a lot of fear about people with psychosis or people with schizophrenia, which is a long-term form of psychosis, and that those people are violent or dangerous. Actually, people with psychosis are much more likely to experience violence than they are to be violent themselves. But if they're constantly attached to the label of psychopath or to serial killers and murderers, then people get the wrong idea. So it's a really important distinction, psychotic and psychopathic. Point 4, clean or compulsive. So I'm sure you've all heard of the phrase, oh, he's a little bit OCD. Yes. That is a really common way of describing somebody who's particularly clean or ordered, who values neatness, or who arranges their things in a particular way, or has particular rituals. Again, there's a famous detective series that involves somebody with an OCD diagnosis, which is different. So obsessive compulsive disorder involves some sort of distressing thought or series of thoughts, and then a series of compulsive rituals which are undertaken by the person in order to get rid of the thoughts or work against the thoughts or try and make the anxiety go down. So, for example, in a cleaning variety of OCD, the thought might be, if I don't clean my house, my family will get sick. And so that person will clean in order to stop that outcome happening. The thing about OCD is that feeling of being able to prevent the thought from happening never happens. Like, you never achieve safety. So just do it over and over and over again, or a certain number of times that feels significant. Being clean or cleaning something to a high standard tends to come with a sense of satisfaction. Like, when it's clean, it's clean. People with OCD don't experience that. Also, people with OCD don't have to experience cleaning compulsions at all. So they might instead think about order or checking, for example, door locks, or is the oven off, or is there any risk of fire? They might also develop particular ideas about what are called internal compulsions. So that's when they have to think certain ways or do things inside their minds in order to stop this negative outcome happening. As you can see, this is a completely different thing to wanting to have a tidy space. So again, when people are described as having particular rituals or quirks, oh yeah, he just has to arrange all his pins like that, then that can be really difficult for people who experience OCD on a regular basis. Finally, ADHD or ASD. Now, these aren't as commonly confused, I find, in literature, but they are things that are very different to anything we've discussed previously. So while we've been talking about mental health problems, ADHD or attention deficit hyperactivity disorder and ASD, autistic spectrum disorder, are what are called neurodevelopmental disorders, which is a fancy way of saying this is how your brain is. So neurodivergent people have different brains or different ways of viewing the world than other people, so-called neurotypical people. With ADHD, people struggle with concentrating, sustaining their attention on things, perhaps moving a lot, perhaps being impulsive. I have ADHD. The way it tends to affect me is a little bit of moving, as you can see, having to clamp my hands down onto the desk so that I'm not waving them in your face all the time. And these things are particularly worse when I'm tired, so I struggle a lot with my concentration and also my ways of relating to pretty much anything that's not in my immediate sight. So out of sight, out of mind is my literal lived reality. That's quite challenging to work with. Autistic spectrum disorder is different. There is overlap. Some people have both. Autistic spectrum disorder is much more about how you interact with the world, and particularly how you interact with other people. This can lead to difficulties in social situations or finding that very draining. There's also a need for order and a difficulty with change. And again, sometimes that can be a bit confused with OCD or that need for kind of like compulsions and rituals, but they have kind of different purposes in autistic spectrum disorder. It's difficult to see characters that are now particularly having more autistic spectrum disorder diagnoses or Asperger's, a term that we tend not to use anymore, whether that's explicitly or implicitly portrayed on screen, because there's a lot of ignorance about how that works, or people think it works in a very specific way, whereas actually people can experience it in lots of different ways. I think there's also a infamous portrayal of a detective on TV where that label was applied to him, and the portrayal was nothing like that. And I think that did not help the situation at all, especially when sociopathic was used alongside Asperger's to try and explain that series of behaviours. It didn't do any favours to the community who had to live with that afterwards. So how do you avoid these common confusions as a writer, or how do you as a reader get to know what's really going on? The most important thing is to seek out people who've got experiences of mental health difficulties or neurodivergent people. For example, the Mind website contains lots of personal stories. You can do research, talking to people who actually experience difficulties like this. And as a reader, just as always, don't believe everything you read in a crime fiction novel, even if it's really, really good. Thank you so much for listening to me today. Take care.